Hello, my name is Dr. James McGregor. I'm a professor of obstetrics and gynecology at the Keck School of Medicine at USC in Los Angeles. My colleagues and I, Dr. Anna Parsons, who's a professor of the University of South Florida in Tampa, and Janice French, who's a midwife who works with us at our LA Best Babies Network project in Los Angeles, wanted to know more about the pathophysiology of intrauterine infection during pregnancy, during pregnancy and after pregnancy. Specifically, we wanted to know about intrauterine infection with group B strep, which can cause both infection at the time of birth and before birth as a form of primary chorioamnionitis with ascending infection of group B strep through the vagina, through the cervix, and into the uterus. We wanted to know how this happened, and we already knew that good images are worth thousands of words of description. So what we did was to do using abdominal and vaginal ultrasound examinations of patients who were pregnant and non-pregnant using albumin X ultrasound contrast media. Albumin X is albumin, which you shake up, and it forms thousands of bubbles, which are highly reflective for ultrasound. This is routinely used in cardiology for studying shunts, as in the heart and other places, where you can actually see where the blood is shunted. So this is readily visible in abdominal and vaginal ultrasound examinations. The first patient we're going to show you is a 24-year-old patient who is being examined by Dr. Parsons in terms of her fertility evaluation. And she's at day 14 of her cycle, which is associated with increased uterine activity, and the 50 cc's of albumin X were actually placed in the vagina, and within hours you could actually see, and you'll see the images now, of where the ultrasound contrast media readily ascended through the cervix, and then there's a to and fro motion corresponding to the antegrade and retrograde contractions of the uterus. You can see it going back and forth, and this is readily seen. In these images of this 24-year-old infertility patient, these are actually sped up, so this is actually faster than you would normally see it. In the second patient, who's a 28-year-old colleague of ours at the University of Colorado, she's 38 weeks pregnant and has an intact mucus plug, and she's having some uterine activity, but not labor. But clearly there's no rupture of membranes, and the mucus plug is intact. You'll see that you can readily see the ultrasound contrast media in the top of the vagina, and then within moments it actually goes apparently up the side of the cervix, where you can see it on the side of the cervix, and enters the lower uterine segment. And then an examination was done with the ultrasound turned off, and you'll see a much thicker representation, much brighter stripe of ultrasound contrast media after the examination. And you'll see that the ultrasound contrast media, or things that could have been in the vagina, like group B strep or other microorganisms, is actually readily transported up into the lower uterine segment and even on the bag of waters. And you'll see that actually quite dramatically with the baby's head and then the bright cap of the ultrasound contrast media within the uterus. After this, the subject did not go into labor or suffer any complications. In both of these circumstances, we can readily see active transport of substances within the vagina that are readily transported up inside the uterus. In the past, in our training, in my training anyway, we always thought most prominently about active sperm and sperm motility as a transport of the sperm up into the uterus and the fallopian tubes. Indeed, Dr. Alan DeCherney, a great leader in reproductive endocrinology, actually described these sperm as if they were salmon swimming up a waterfall. These observations show that that's not necessarily true, and that there's active uterine transport of substances within the vagina, including sperm and microorganisms, up into the uterus. Actually, this had been known before. Dr. Edward Newton, who was then the chairman of OBGYN at Northwestern in the 1960s, actually did similar experiments with lampblack, which is carbon, which he placed on the cervix at the start of vaginal hysterectomy. And then within 40 minutes, where he had completed the vaginal hysterectomy, you could readily see the segments of the fallopian tube that actually were filled with lampblack, quite obviously. Studies done in Germany and in England in the 1970s and 1980s readily showed, using nanoparticles and sometimes radioactive nanoparticles, that actually there was rapid transport of substances from the vagina into the uterus. And this has become a standard part of endocrinology, reproductive fertility workups, actually showing active transport. And in the case done by Dr. Parsons, the patient is being worked up with a ultrasound contrast media histosalpingogram, which is now standard in many centers. So in fact, this uterine activity is well characterized by many in OBGYN, but not so much in routine practice or like people like myself who are mainly interested in infectious disease. What to call this phenomenon is of interest. Certainly reproductive endo people think this is just all normal and that the uterus has regular built-in contractedness physiologically. We in obstetrics sort of think that the uterus is quiescent, but we also know that the uterus contracts approximately every 4 minutes during pregnancy. The residents at the University of Colorado thought that my term for this, which was active uterine transport, was a little corny, and actually coined the term upsuck. So this they called uterine upsuck. And I think this allows us to understand more about how infections occur inside the upper tract tissues, including the uterus during pregnancy and before pregnancy, and even the fallopian tubes. It had also been known in animal models, especially for different kinds of sexually transmissible infections such as gonorrhea or chlamydia, that in monkey and actually rabbit models, that there's active transport of these microorganisms within the uterus itself and up into the fallopian tubes, oftentimes within minutes. And so these principles had actually been well established, and you could see from these pictures how organisms such as group B strep may readily ascend up into the upper reproductive tract tissues and thus infect the baby even before birth. And I think this is a new phenomenon that we need to recognize, that there can be primary chorioamnionitis caused by group B strep and other microorganisms without obvious rupture of membranes or even the onset of labor. And I think this has actually been well described too by people like Bernersky and others interested in the pathobiology of intrauterine infections and chorioamnionitis. Certainly Romero has shown in recent studies that you can actually have large colonies of microorganisms existing within the bag of waters, especially around the cervix. And even that was one of those pictures was actually featured as a cover of the American Journal of Obstetrics and Gynecology 2 years ago. So in sum, I think we've shown with these illustrations of the active uterine transport that microorganisms and other small microbes, which are the same size as sperm, may be readily transported up into upper tract tissues, and that can account for both primary and secondary infections of the bag of waters, thus chorioamnionitis, and even the baby, him or herself. And I think this is a readily understood cause of intrauterine infection, which could cause stillbirth or intrauterine death for these infected children. Multiple studies recently have shown that large numbers of stillborn babies are actually infected or inflamed, and that is actually the cause of their death in both studies in Europe and here in the United States. So these pictures that we've shown you inform how these infections may have occurred and give us insight in terms of how they may be prevented. I think in terms of group B strep, the key things are to follow the CDC's recommendations of doing routine screening invariably at 35 weeks, and also do the screening and treatment of urinary tract infection and asymptomatic bacteriuria of over 10 to the 5th group B strep at the first initial obstetrical visit. And these are now recommended by the CDC and are shown to be approximately 90% effective in terms of reducing risks of group B strep infection of the newborn. But I think we can do better, and I think these images will actually inform new research protocols which allow us to do even better in terms of understanding the importance of immunity and host defense mechanisms for group B strep, or even better ways to use limited chemoprophylaxis. Now, my colleagues will actually describe to you several other cases which were involved with stripping of membranes, which I think we could actually suggest to you massively transports microorganisms into the lower uterine segment and may increase the inoculum of microorganisms that the fetal trophoblast and the maternal decidua have to deal with. So I think we could recommend not doing stripping of membranes, certainly in the presence of group B strep or other known pathogens such as E. coli or other microorganisms. So I think that's a practical takeaway from these images. And now my colleagues are going to present and show you several other cases of group B strep which appear to be associated with failed prophylaxis or with more aggressive infection, possibly induced by uterine contractions or perhaps even manipulation or stripping of membranes.
Each of these babies suffered ascending GBS infection, possibly due to cervical exams as seen in the previous ultrasound illustrations.
Thank you very much for your attention.